So this is not a training course, but a question and answer session for our registered candidates who are already undergoing some online server-based courses. So I'm repeating, this is not a course, but a question and answer session for registered candidates only. So today we have got some questions from registered candidates. So the first question, which has been posted by Dr. Miridula, is uterine artery in a non-gravid uterus. I'm repeating, this is a question and answer session, not a course. This is question and answer session for those who are already undergoing our course. First question from one of our registered candidates, her name is Dr. Miridula, is that uterine artery in a non-gravid uterus. Second question from Dr. Jatin, differential diagnosis of endometrioma and a dermoid cyst and how we can differentiate it from a simple cyst. And third question from Dr. Cyst, I'm very sorry if I am pronouncing it wrongly, is that how to see ovaries if they are adherent to posterior wall. So we will take these three questions. These are already posed by these candidates. We are having a group where the registered candidates are posting the questions or they want a clarification on any specific point. Now, starting the first point, the first question rather, uterine artery in a non-gravid uterus, which is posted by Dr. Miridula. So Dr. Sandhya, being a gynecologist, first of all, tell me, have you completed the Doppler ultrasound from our server?
No, sir.
This is the point. Okay, so this all is the course which you have to undergo, but the question posted by a candidate who has already undergone this course is the uterine artery in a non-gravid uterus. We will not discuss here the uterine artery, but we will discuss the question. Now, Dr. Sandhya, you are a gynecologist. You tell me why we are seeing this uterine artery. What for is this uterine artery? Okay. Putting it in a simple way, what will you expect in a uterine artery of an infertile patient? Dr. Sandhya. You are probably muted. I will send you unmute invitation. Yeah, Dr. Sandhya.
Yes, sir.
What will you expect from a uterine artery in an infertile case?
In infertile case, uterine artery, sometimes if there is any some infection or other thing, flow is increased.
Okay, you are telling me flow is increased in an infertile patient, right?
Yes, sir.
Think logically. Ultrasound is not a photography.
Yes, sir.
Will the blood flow, will it be increased or decreased in case of an infertile patient when we are talking about this uterine artery? Decreased or increased? Think. It will be decreased, not increased. Now, yes. How that will be picked by ultrasound, we have discussed it in our course that there will be this systole, this is the systole, and this is the diastole. Now when we are taking the index I mean the S by D ratio of this systole upon this diastole. Dr. Joseph,
Yes, sir.
do a simple math. Okay?
Yes, sir.
For 2 minutes, you are not a doctor. You are simple doing a math. If the systole is 10, how to trace the uterine artery? That is part of our course that you have already completed. Or if you have not completed, you will complete that. Now, do a simple math. If this systole is 10 and this diastole is 2, I am repeating, if systole is 10 and diastole is 2, how much will be the S by D ratio?
5.
Okay, hold on. Remember this 5. Very good. So 10 upon 2 is 5. Now, due to any reason, if this is not now 2, this is 1. So 10 upon 1 will be how much now? S by D ratio?
10.
Now, with decrease in diastolic flow, is S by D ratio increasing or decreasing?
Increasing.
Dr. Sandhya, back to you.
Yes, sir.
What you are taught, this is not problem with you gynecologist only. You are not the first person. What gynecologists are thinking, I don't know why. Please pardon me for that. High resistive index does not mean that something is high over there. It is actually the drop in the diastolic flow that we are having a low, high resistive index. I am repeating. It is due to the drop in the diastolic flow that the S by D ratio is increased. Now, whenever, hold on. Now, whenever the books are writing high resistive index, it simply means that the S by D ratio is increased. Now, if S by D ratio is increased, what is dropped?
Diastolic.
Very good. So coming back to your first point of the question, you told me increase. Why? Because it is feeding over here in your mind that the resistive index, so resistive index is also nothing but the S by D ratio. So whenever you are stating or you are reading somewhere that there is high resistive index, no way. It means that the diastolic flow is increased. It actually means that this is due to the low diastolic flow. Have you got the point?
Yes, sir.
Now, coming back to the question, what will you expect in a uterine artery of an infertile patient, Dr. Sandhya?
So, increase.
Low diastolic flow or high diastolic flow?
Low diastolic flow, sir.
Very good. Now see, you know it, but my job is to convey you the simple thing. These S by D ratios, how to shake your neurons.
Yes,
Okay, so now coming to the question. What will you expect in a uterine artery of an infertile patient? A low diastolic flow. Now,
yes.
you might be thinking, how much low? For that, we are having charts. These charts are already discussed in your course. You have to go back to the chart. So this is the chart over here. So now, for example, this is 0.55. This 0.55 resistive index of 0.55 means that the diastolic flow to this ratio, S by D ratio, is, for example, this much. For example, for the sake of argument, this much. Now, coming back to this chart, if this 5.5 is not now 5.5, but it is 7, for example, for the sake of argument, if it is not 0.55, it is 7. I told you, for the sake of argument, we will say that this is 0.55. With this much of diastolic flow, try to understand the concept. With 7, what will you expect this diastolic flow to be? This side high or this side low? Dr. Sandhya, back to you.
Yes, sir.
Others can comment in the comment box.
So please repeat your question.
Okay, I am repeating the question. I told that for the sake of argument, I take that this resistive index of this uterine artery is 0.55. If it is not 0.55, but if it is increased and has shooted up to 7, what will you expect this diastolic flow to be? Low or high?
The low, sir.
Very good. Now you are coming on track. Now, the high diastolic flow means that the diastolic flow should drop. Now, go back to this chart. Now, coming to Dr. Sandhya again. Dr. Sandhya, I am not torturing you because you are a gynecologist. You should know these points. That is why I am coming back to you time and again. Because this is gynecological related question. Now, in an infertile patient, that resistive index, what you will expect to go up or to go down? If normal is 0.55.
So go down.
Think again. Resistive index, will it go up or down?
Sir, in uterine dilatation.
No. In infertile patient.
Yes, sir. Yes, sir. Infertile patient resistance will be high.
Very good. Now, wait. Now the point is how much is the normal? Okay. So we will not discuss the uterine artery, how it looks in first trimester, how it looks in second trimester. This is all in the course. We will discuss here the question. Now, I am very sorry for these questions. I'm having very long explanations because I don't believe in giving one line answer. Now, let us go to this chart now. Now see over here. Let me zoom on it. Now, in fertile patient, now see, in fertile patient, the RI is 0.67 with a deviation of 0.07. So forget about the deviation. It is 0.6. So what will you expect in an infertile patient? A high resistive index. So here is 0.68. So the point is, if you are able to get a uterine artery, and if you know how to do this simple math, what is this resistive index? Resistive index is nothing but this S by D ratio calculated in the formula. If your patient is giving you 7, does it mean that this low diastolic flow, or in other words, this high resistive index can be the possible cause of her infertility? Am I right or wrong?
Yes, sir.
So now coming to the question. What was the question? Role of the uterine artery in infertility. So this is the role. This way you have to see for this uterine artery, and this way you have to see for this resistive index. So remember, if it is dropped below if it is increased above 0.60, it means that you are dealing with a high resistive index, which means that the low diastolic flow is there in the uterine artery, which can be the cause of the infertility. Not only in infertility. See, not only in infertility, but the uterine artery. Now see, okay, just skip this. Yeah. So if the patient, now see, if the patient is suffering from recurrent spontaneous abortions, now this is the study which is conducted. I will not go through whole of the study. I will give you the result. RSA here means recurrent spontaneous abortions. Now, the uterine artery PI value in recurrent spontaneous abortion patients were significantly higher with respect to found in the control group. It means even after the patient has conceived, and if the resistive index is high, there are high risks of having the abortion. So if you want, I can send you this study. So I will send you this study. This is the long study. I gave you just a summary of this study. So the point is that we have to keep an eye on the resistive index of the uterine artery even after the patient is conceived, because if there is a high resistive index, there are high chances that there will be a spontaneous abortion. So this is the role of the uterine artery in infertility and even after conceiving. Now this is another study. I can send you the PDF of this study, role of the Doppler in the unexplained infertility. Again, what the result is showing over here, the result is again showing that the high pulsatile index, which simply means that the systole upon diastolic ratio is increased, which Dr. Joseph has given us the maths, simple maths. What is the resistive index? What is this PI? This is nothing but the calculation of systole upon the diastole. So if there is infertility, see for the uterine artery, maybe that you are dealing with a high PI of the uterine artery, which can be cause of infertility in that given patient. So this was a brief explanation of the answer. So now moving to the second question. So any counter question from anybody regarding this question? I will not take next question from anybody because these questions are already framed. We have to discuss these questions, and the next questions you can post in the your batch group. We will discuss in next class. So regarding this, if you have any counter question, you can post in the comment box. Where is the comment box? Comment box is again in the more option. You have to search for the comment box, which is in the more option by the name of the chat. So you can go there, you can put a counter question, or if you have any more confusion regarding this question. So I'll be waiting. So I'm keeping an eye on the comment box. Hurry up if you have any doubt or you want to put any counter question or more explanation. Okay, somebody has posted, what is pulsatile index? Probably this candidate is not registered for any course. That is why he is having this question, what is pulsatile index, which is posted by Dr. Abdul Azad. See, this is the question over here posted by Dr. Abdul Azad. What is pulsatile index? So I told you that this is the question and answer session. We are not taking a course. This pulsatile index, resistive index is in detail in the courses. But I will give you a very short reply. Pulsatile index is nothing, which I gave in my explanation. This RI, PI is nothing but the ratio between the systole and diastole calculated in a formula. Now, what is a formula? That is very lengthy, which will take about 1 hour, which is in detail in our courses. Okay. Another question posted by Dr. Pooja. At what menstrual cycle we should check for this uterine artery? Very relevant question, very good question. Dr. Pooja, I told you that I will send you this PDF. I will send you this PDF. Dr. Pooja, if you can raise the hand, I will unmute you. so that we can discuss. Hurry up. If you can raise the hand so that we can unmute you. Hurry up, please. What is her name? Dr. Pooja. Now there are many candidates which are over here. Pooja Kesri. Yes, got it. Dr. Pooja Kesri, we have sent you the unmute invitation. Hurry up, accept this. Accept the unmute invitation.
Hello, sir.
And say hello on accepting. Dr. Pooja, I'm waiting for you. Hurry up.
Hello, sir.
Speak up, Dr. Pooja.
Hello, sir. This is
Say
Dr.
hello.
Pooja here.
Yeah, Dr. Pooja, I already told that I will send you this PDF file, but let us discuss with you if you are in day 1 or day 2nd, and if you are in a day 12th, where will you expect high flow in the uterine artery? In earlier cycle or towards ovulation?
Towards ovulation, sir.
Very good. Towards ovulation. Now, there are different studies which are conducted. Some are conducted at day 2nd and some are conducted at day 12. Now, depending on which study you are seeing and which tables you are using, accordingly you have to select the patients, whether the patient should be scanned at ovulation or near ovulation or earlier in the cycles. So in this study, I've not gone through this study detailedly because I am having multiple studies over here. You have to see the table. There is a table. There is always a table with these. Yeah, this is the result over here. So this is the result. Now, in over here, the uterine artery endometrium during menstrual cycles. Now see, this is written. So the point here is that it depends on which chart you are using and the background of that chart, whether the study has been conducted in mid or in early. Accordingly, you have to decide. But the main point is that you should know that in the start, the diastolic flow will be low, and in the mid cycle, the diastolic flow will be high. Now, putting a counter question, Dr. Pooja, tell me what will happen to the resistive index as you are moving from early to mid? Will it increase or will it decrease?
Decrease, sir.
Very good. Now you are coming on track. It will decrease because the diastolic flow will increase. Very good. So, Dr. Sudhir Kumar is questioning how to locate the uterine artery easily. Probably that person has not gone through the course. I am telling time and again, this is a question and answer session. How to locate a uterine artery? That is about a 4 hours job on our server. There are about 4 to 8 classes which will teach you how to locate the uterine artery. Okay, so moving to the second question. The second question, what was the second question? Whosoever is right now live with me, I mean, like there are many candidates with me, about I can see are 88. Yeah, there are 88, but only about 4 to 5 are unmuted. So I am requesting these unmuted candidates to stay unmuted so that we can discuss the second question. So the second question was, I'm recalling from my memory that how to differentiate a dermoid from an endometrioma and a simple cyst. Dr. Sandhya.
Yes, sir.
Yeah. Again coming to you, and Dr. Pooja. You're Dr. Pooja, right? Dr. Pooja Kesri. Okay, Dr. Sandhya.
Yes, sir.
Being a gynecologist, now this question I don't know why he has posted, because we are having a detailed class on this dermoid, on endometrioma on our server. But let us take a quick recap. As the question is already posted, what will you expect in a patient? I mean the pain. I mean pain. Forget about ultrasound for 2 minutes. I mean pain. What will you expect if the patient is having a dermoid and if another patient is having an endometrioma? The pain, how the pain will be different in two.
So in endometriosis, there is continuous dull pain.
Hold on. There will be continuous dull pain. That is what you are stating, right?
Yes, sir.
Okay, I'm taking it. Okay, then in case of dermoid,
So in endometriosis, pain will increase sometime according to cycle.
yeah, you are knowing the things, but you are a bit confused. I don't know why. You please think this is all what we are discussing in the courses. I am skipping these slides because this will take about 4 to 5 hours. Now let me go to yeah. So now, for example, you have got a cystic lesion. Dr. Pooja, are you there? No. Dr. Sandhya, if you got a cystic lesion
Yes, sir.
on ultrasound, now you are not very good in ultrasound, but you are a gynecologist, right? In case of a dermoid, will you expect a dull pain or cyclic pain?
The dull pain in dermoid.
Very good. Dull pain, dull and persistent pain. Am I right?
Yes, sir.
In case of dermoid, please note it down. But in case of endometrioma, will you expect a dull, persistent pain or cyclic pain?
Cyclic pain, sir.
Very good. So note down second point. So I am replying as well as discussing. So dull and persistent pain, dermoid. Cyclic pain,
Endometriosis.
endometriosis. Now, coming to the ultrasound picture now, because we are discussing ultrasound. Will you expect any solid mass like hair, sebaceous glands in case of an endometriosis? Yes or no?
No, sir. No, sir.
No. Note it down. Point number third. If you will put a color box, we are just differentiating. We are taking questions. We are not taking a course over here. In case of an endometriosis, Dr. Sandhya, again to you. In case of endometriosis, is endometriosis a live tissue or a dead tissue?
So raised vascularity.
No. Wait. Don't straightly jump high up on the mountains. You are knowing the things, but others may not.
Okay.
Is it live or a dead tissue? Endometriosis, yes or no?
Yes, sorry, sir.
Is endometriosis a live, active, or a dead tissue?
Live, sir.
Live. Hold on. Is a dermoid also equally live?
No, sir. It's
No. That is why my answers are a bit lengthy, because these answers will be there in your mind for lifelong. Now, keep this point in your mind and then put color. Now, if you put color, will you expect an endometriosis to take color? Yes or no?
yes, sir. Endometriosis.
Yes. Will you expect a dermoid to take color?
No, sir.
No. Note it down. Third point. In case of a dermoid, it is avascular. And if it shows vascularity, it goes in favor of endometriosis. Okay.
Yes, sir.
Now, will dermoid change overnight? I mean, if I am scanning today and if I am scanning day after tomorrow, will dermoid change in a span of 24 or 48 hours?
No, sir. No, sir.
No. Will endometrioma change?
Yes, sir. It can change.
Yes. This is the point. So if the picture is changing dramatically, then it is going in favor of endometriosis. If it is static over a period of time, then it goes in favor of dermoid. So I am requesting you to go to that class that is of female pelvic scanning. There we have discussed that thing in detail, so I quickly gave some important points. So if you have any counter question, anybody among the, now I am having 91 candidates over here. So if you have any counter questions, please quickly hurry up, send it in the chat box. Hurry up, please. So these are the questions. Sorry, this is the explanation to those questions which has been posted by the candidates. So let us quickly go to the third question. What was the third question? Let me recall. Yeah, the third question was how to locate the ovary if it is not in that position where I am expecting it. So Dr. Pooja Kesri is telling me how to differentiate a simple cyst and a dermoid cyst. Dr. Pooja Kesri, raise your hand. I want to unmute you. Hurry up, please. Dr. Pooja Kesri, raise your hand so that I can unmute you. Yeah, got it. Dr. Pooja Kesri, I have sent you unmuted invitation. Say hello.
Hello, sir.
Yeah. Now you pose the question, differentiation between the simple and dermoid cyst. Yes or no?
Yes,
Is your question?
yes, sir.
Yes or no?
Yes, sir.
Yeah. Okay. Now a simple cyst and a dermoid cyst. You are confused between a simple and a dermoid cyst. In simple cyst, we will be having the simple cystic criteria, which are 4, which we have discussed. Jet and echoic with clear walls with posterior enhancement. This is the cystic lesion, simple cystic lesion, and it is not usually more than 4 centimeters. In between 4 and 5, it is borderline. But beyond 4, that is abnormal. That is not simple at all. Now, in case of a dermoid, we have just discussed it that the dermoid will have a solid mass, not always, but in most of cases, the dermoids will have the solid predominancy. It can be of any mixed eco texture, but there will be not always 100%, about a 90%, there will be a solid predominancy. But why will you expect a solid predominancy in case of a simple cystic lesion? And if a simple cystic lesion is a simple follicular retention cyst, if you will rescan, it will not be there, or it will be regressing in next menstrual cycles. But if it is a dermoid, it will have a dull, persistent pain. And if it is a simple dermoid cyst, simple cyst, in comparison with the dermoid cyst, and if you are dealing with the dermoid cyst, we have just discussed about the infertility. The infertility, there can be a cause, and the cause, one of the cause can be itself the dermoid. So these are the multiple things which you have to keep in mind when differentiating the things. So I will request you to go back to the class and you can repeat. The beauty of the server-based classes are that you can repeat it. Okay. So the third question, what was the third question again? I have skipped it. Yeah. How to locate an ovary if it is not located in its position. I told you in the class, time and again. I showed you multiple patients. Even if you will come here and you will sit next to me, you will not see these patients over here, because this is the amalgam of many decades. So now see, first of all, what you have to do, you have to keep anatomy in your mind. You have to swipe the probe. First, you know where to put the probe? Just above the pubis symphysis. Then if you are scanning the right ovary, you have to hit from the left ovary. Left side. And if you are going to scan the left ovary, you have to hit the beam from the counter side. It means that the beam should pass through the bladder. Bladder is the window. So the point is over here, if you are scanning the left ovary, don't put probe on the left side. Because that way, you are not making a window which is bladder. Now, coming to the question. How to locate an ovary if it is not in that position where I am expecting it. So first see the ovary, how it is looking like on a real patient. Now I am showing you real patients over here. What else you want? If you will come over here, you will see same thing. So when we are scanning, first we are starting from the mid. Then see, this ovary has to, I have to put the probe. For example, if I want to see the right ovary, I have to put the probe toward, I have to drag the probe towards the left side. Now the question may arise, how much I have to drag? I don't have any answer. Why? Because the ovarian position is different from a patient to patient. So you have to make the adjustments, small adjustments of the probe, but the key point is that you have to hit from the other side. So this is the basic scanning techniques, which is of uterus, long-term section and transverse section, which we are discussing in great detail in our courses. Now the point is, now see, let me pause over here. Yeah, this is the ovary over here. Now pay attention. This is the ovary over here. This is the right ovary. Why this is very clear? This is the basic machine. This is not the high-end machine. And this is not the TVS. This is the transabdominal probe, because I am hitting from the other side. Why? Because I want to make a window which is of the bladder, which I cannot make if I will put this probe on to the right side. So the clarity of this ovary is very high because I am making the beam to hit. Now see how clear the ovary is. Because I am hitting the probe from other side so that it will be hitting, it will be crossing through the bladder. Now the ovarian location depends on the broad ligament. Broad ligament is encasing the ovary. It can be anywhere. Rightly the question is posted that if it is adherent to posterior wall, not only in posterior wall, it can be even in cul-de-sac, near cul-de-sac it can be. So you have to search for the ovary. You have to search for the ovary. But the key point, now see, even the Doppler, we can make it out. Now see how beautiful the ovaries are over here on color Doppler. We can even see that. But the key point is you have to hit through the bladder. So I'm having one more case in this. Just hold on. I will show you one more thing. So see, this is the patient over here. Now tell me honestly, if you will come over here and you will sit next to me for observership, will you see this much of clarity? No, patient will not allow you to touch her. And even if she will allow her, will you see this much of clarity? How to rotate the probe and the monitor on the same time. So this is the server-based courses which we are providing you. And right now we are only taking the question and answer sessions. So now see, this is the probe position over here. This is the probe position. Right now we are scanning the uterus in the long-term section. So I am skipping that. So that is not the question over what I have to answer. The ovary. Now see. First of all, this is the transverse lie of the probe. If I want to see this sided ovary, I have to drag the probe towards this side so that it will be hit through the bladder and hit this ovary. This is the point. Now, you have to search for the ovary. If you are not getting the ovary over here, now see here, the ovaries are very clear. This is the ovary over here. This is which ovary now? Now you can make out. Now see, this is which ovary? This is left ovary. This is left ovary. Now see, this probe is towards the right side and it is tilted so that it is hit over here. That is why. Now see, this is not a thin patient, but the ovaries are very clear. Why? Because simple hitting through the bladder. Now, if the uterus, let me go to the uterus. Now see, this is the ovary, not a TVS. Now see, I'm proving this is not a TVS. This is the transabdominal probe. Why the clarity? Because first of all, we are making the adjustments of the machine. and the machine adjustments are in the course number 1, which is physics and machine settings. Very important, very important. Set the machine first. See the focal zone, see the TGC, see the depth. Now what we are doing, we are taking the Doppler from the ovaries, So this all is discussed in your course. So the key point over here is that, if the ovary is adherent to the posterior wall, you can see it over here, but you can more see in a longitudinal section in that case than in a transverse section. This was the one line answer for that question. So you have to then make more, do more longitudinal sweeps. If the ovary is in posterior wall, then you will find it near cul-de-sac. So this way you are doing these scans, and this was all about the 3 questions which we have discussed it over probably 1 hour. So this was all for this session. I hope that you have enjoyed this session. This is all for now. In case you will be having more questions, we are arranging the next session most probably at the end of this week or next week. In the start of the next week, you will get notification in your WhatsApp groups. So meanwhile, please complete, revise, don't be in a hurry when you are undergoing these server-based courses. Take your time, revise the topics, and whatever questions you are having, we will discuss those questions this way. Okay. Thank you very much. God bless all of you. See you soon.